There's no pop. Try it again. And relax. One more time. And relax. So do you still feel like the left side is the stuck side?
Yeah.
Oh, okay, you're convinced.
Yeah.
So usually it's one side that you're doing the majority of the work, pretty much 80% of the work. And so if you glide, if this is the jaw and you're gliding on the outside of the teeth, you're going to get into this little muscle. It kind of feels like this. It's stringy and tough, and that's the medial pterygoid. And you're going to use the flat of your finger, and you're going to just put a gentle force on that. You're trying to peel it open that way, because when it gets stuck, it pulls it inward, and then you'll see the jaw go kind of sideways. Okay, so I'm going to tilt you over just a little bit, and then open your mouth. Okay, real easy. Oh, open wider. Keep it there, right there. No tapping, just just rock down that way, right there. So it does feel really tough here, but that doesn't confirm the result. The result I'm looking for is that pretest we did, everything we do, we're going to compare with a pretest. You want to be able to show somebody the improvement and prove that you're effective.
So you're moving it out.
Straight lateral.
Okay.
Yep. Oh, it's starting to move now.
And
then
he's
I'm
just
also
relaxing into it.
yeah, and I'm feeling for a change, and it can change pretty fast. Like it's already moving. So it's usually 60 to 90 seconds before I see a big change, and it's roughly 80% on one side. So oftentimes I'll only work one side, because there's, you can get a lot of change, but there's a bit of rebound too. So you want to get one side ahead of the other. Now it feels like it's let go pretty well. So see if you were right. See if it was the left side. Try. What's that feel like? Yeah. And then try your pretest. See if is that better, or is that still the same? Oh, you're making it now. Sometimes the click is on the opposite side, because the gripping's here and then the weird translations on the flip side. So don't get distracted from that. I just use that as a reference. When there's a click, there's an issue. This whole class, we're going to overweight the problem. In other words, if your right side's stiffer than your left, you're going to work twice as much on the right. Do you guys notice anything off the top? Yeah, the right's lower, and which usually means she's right-handed. Are you right-handed? Okay. And I'm going to teach you guys a whole pattern that's super common with right-handers.
She pulled forward a little on the right side also? Like
Yeah, it's depressed and internally rotated. Yep. But that's the most common for right-handers. If you're writing, that's the same thing. It's internally rotated and depressed. So sometimes with that, the reason I'm looking from the side is I want to see if the mid-cervicals are doing all of that. And it looks like they are. So you know that the base of the C-spine is stiff and the upper C-spine is stiff, because all our movement is out of this pocket right here. So we want to change that. So, and then as far as the forward bend, the thing that I'm finding, well, usually I ask people, do they feel it? And do they feel it down into their mid-back? Because it could be originating in the mid-back. And then I'm also looking to see if they can actually get their chin down towards their chest. So, and then for extension, I'm looking for her to be able to look up towards the ceiling without any pain. And if her upper thoracic is really bad, she wouldn't be able to pull that off. And if there's a huge imbalance between the right and the left, you'll see that she drifts over, and she'll drift away from the tight side. So come back to center, and let's see if, try extension. Forget everything I said, and try looking up towards the ceiling. You see her leaning in one direction or the other, or does it look straight when she does that?
But her
Yeah, that's what I'm talking about. If
Yeah.
she's leaning over towards one side, so
towards her left.
So I'll show you a couple ways to intervene on this. What do you guys see as her main problem when she did all those movements? What's the biggest restriction? Her left upper thoracic, lower cervical, right there, was impinging her left rotation. So that's the thing that we want to change first. You always start with the worst problem first, and then you work your way down the path. Do you have any pain when you got all the way to the left, when you rotated that way all the way? That way all the way? Is that painful? Okay, all right. So I'm going to go just lateral to the spine there and feel for that tension there. Anytime you do a palpation, you're looking for texture, and the way you find the textural difference is cross friction. So, but in certain spots, you're just going to adhere to that rule no matter where you're at. So I'll keep reminding you of this. So in this case, I'm going to palpate up this direction, and I'm going to palpate this direction, because of course there's a couple different cross-directional fibers here. And I'm gonna stick on the spot closest to the spine. Yeah, it feels like right in there. So it's a little bit lower than T1 area. It's more like a T3, T4, right there. So I'm going cross fiber to feel what the texture's like. And she's not severe. And using a towel to get a good grip on what I'm doing. And I'm gonna hold right here where I feel it restricted the most. And then keep your arm real relaxed. You're gonna stay over the top of your work here and then turn towards me. Can you handle that, Nico? Mm-hmm. Okay, so go all the way to your end range. Let's see what you got. That right there? Mm-hmm. Okay, relax a little bit. So I feel that tissue tension right at the end range, and I'm gonna toy with that. Always at the end of a stretch, you don't wanna hang out there because it's bad for the joint. So I'm gonna have her move in and out of it. So all the take-home stretches I show you guys, it's gonna be constant motion because static stretching doesn't work and holding the end range hurts the joint. Okay, relax a little bit. So I want her to challenge the movement because I want this spot, I'm designating the stretch. I want this spot to stretch the most. And then relax. Go again. So I'm not using the point of my elbow, that would be more like that. I'm using the flattest part I can find, but with decent leverage. Go 3 more times. Feels like it's letting go too, so I'm always feeling the density. More. Okay, come back. So part of that active motion is strengthening that movement too, while you're releasing it. Let's turn you around, and then turn your head left all the way. Let's see what that movement looks like. You guys see the difference?
Yeah.
So we just did like 3 minutes of work.
Yeah.
So there's one option. This thing's called the edge, and they look like construction tools or, I don't know, straight out of a car engine. But having the kind of weight and having the kind of leverage is really important. You'll see, it just makes it super easy. I like the metal ones instead of the plastic or ceramic. I brought a plastic thing for you guys to check as well, because this you can just scrape and no big deal. These things, they have these beveled edges and these different curves to them. Got a thumb power deal here, and you've got a trigger point end if you want to work trigger points. And then that justifies me really working it. So I'm going to use this guy first. So we've already greased her down. So I'm going to start right next to the spine, because the whole point in this is spinal decompression. You're taking whatever tendon, I was going to show you guys one palpation trick. If you go right along the laminal groove here, you know, the part of the spine where there's that little dip by the transverse process, you can tell the whole story right here. I can feel this curve. Do you feel how the vertebra is kind of pushing out right there? I can feel it. So when you assess down the spine, trace the laminal groove, and then you'll feel the divots, you'll feel the bumps and extrusions where things are twisted. So you know that this segment's twisted right there. So you can see how my thumb is rolling around it. So you could use a curved or a flat tool. You guys can experiment with these. And I'm just going to grab where it's stiff and then move out. So I've got this passive approach, which is more relaxing, and then I've got an active approach where I could pin it down like we just did and turn your head to the right all the way, and then relax. So one note of warning, they're going to be red and sometimes bumpy and stuff like that. Oh, that's great. And then one more time. And I think that's a good thing because, ooh, relax a little bit. I lost it. Right there. Go for it. A little more. That's it. Okay. So his right side, when he was going away from the triggered nerve, he would feel this impingement down into the front of his shoulder. So often that's the scalene, or SCM that's tight. So if somebody's sitting and you're palpating, you can go front to back and feel what the texture's like. And especially right around the collarbone. Move him this way, just very gently. So, and then you're going to be scraping down this way. So you're going kind of cross fiber. But you don't have to push hard. It's more, it's weird. It's like a magic trick. Once you get the fascia moving, you're mostly moving at a 45-degree angle, slightly cross friction, and not pressing hard. And you'll feel the texture start to change. So that's what you're doing when you're pushing through. You're getting a sense of how much restriction is there. And then you can also go this way. So I like to palpate under the C-spine and then feel this direction, always cross fiber. Oh, he's got a lot of tension right there. You can even see it. So I'm going to move him right there. And then, okay, so I've got a couple surfaces I could use. I like the small surface to begin with, so I could get a sense for what I'm doing, and then I can flip to a larger surface. And you see I'm going easy. It doesn't take that much pressure. And I'm also extra sensitive to what's going on. I feel this lump of tension right there. So that's going to be a big fixation point I'm going to work on. So I'm going origin, insertion, bouncing back and forth, and feeling, okay, what needs it the most? The thing you don't want to do, of course, everybody here knows that. Don't hit the carotid artery. So of course, you're going kind of back to front. It's starting to move right there. Do you feel like this pocket is starting to soften? Can you tell?
No.
Okay. I'm not going to get any feedback from you.
No.
No. Cool. Then for me, I'll have to just sense it. Starting to give. So we don't know that this is the source of his impingement. I'm guessing. I call this the psoas of the neck and shoulder. You guys know what a pain it is to work on the psoas, all of you, but how critical it is. If I were to pick the two most important muscles, the most important hip girdle muscle, the hips are the lower back. I'd say the psoas is, because it's directly tied to the back. If I were to pick the most important shoulder girdle muscle, I'd say the subscap is. And yeah, and the same thing. It's like a deep internal rotator flexor type thing. So those are things I always tell.
Those to the list today.
Oh, we're definitely getting those. So anyway, he's getting softer through here, but still really stiff right there. That could be a big source of his impingement. So with the subscap and the psoas, I'm going to show you some tricks to getting in there. I'm only gonna do a handful, like 10 or 12 passes on it, and then give it a break and see what's happening, and see if I notice it's already softening quite a bit. So I'm comparing it to the flip side and comparing it to the original tension I found. Let's bring you up to standing, and let's just test and see if that was part of the problem. So my favorite way to assess here is bringing both arms up. Don't let your hands touch, because if you touch your hands, you start cheating it through your mid-back, and then flex all the way to your shoulders. So bring them all the way back in. See,
Hurts on the left.
on the left, okay.
Hurts has fun.
Okay, isn't that interesting? Because you see, it almost looks like her range of motion is better on that side than this side. It glides back better, but there might be a restriction down there that's impinging it. She does look, I always look at the rotation too of the humerus. This one's a little bit externally rotated. Now you can see the difference. See what, once she relaxed a little bit, do you see the difference in the level of the hands? This side is a little bit higher. So move your hands closer together,
Yeah.
closer, closer, closer until they touch. You can't really tell, can you? Maybe you can.
So we want humeral head to be how lined up? Straight?
Well,
straight back overhead?
First of all, if you see that her ribs are coming up a little bit,
Flare.
then you know she's cheating it, because it's not flexing well enough through there. Okay, so I'm going to show you. This one's going to come down. So I'm going to go on the anterior face of the scap this way, just with straight hands, but also you can use a tool this way as well, where you go in this way. It seems pretty brutal, but it's more supportive. You've got the stability where your finger joints aren't getting smashed. So a good way to go about this is, if you put a leg up, you can, I'm going to go without the tool for now. You can explore and feel where the restriction is. So I'll show you without this. Just tell me if it's too abrasive. The way I'm getting in here is sliding along the rib cage. So, ooh, oh my God, that is jumped up. So, yeah, can you handle that one?
Yeah.
Okay. So one of the tricks is, if you internally and externally rotate, kind of like with the psoas, if you flex and extend, you can feel where that thing's running, and you can feel the texture of it. And as I externally rotate, putting that on a stretch, boom, there it is, deep issue. So you know what's dictating my finger position is her rib cage. I'm slipping along the rib cage towards I'm going kind of in and under,
Mm.
so that way. And I'm letting her ribs support me. So think about the anterior face of the scapula, the front side of the shoulder blade. That's the muscle that you're going for. And now I feel it starting to let go. So now I'm just exploring which motions are most restricted, and this one certainly is. And then the other part is, if a person's really restricted, like post-surgical,
This frozen shoulder
yeah, this is the best move for frozen shoulder, and it's usually the most necessary one. And also post-surgical, so it improved significantly. But you saw how I had to gauge it based on her pain tolerance. So that's it. One of them is across the body, so let's bring this arm across the body this way. And the best way to test it, he's got the assistance of gravity here, which is not fair. So when he's standing and doing that, or sitting and doing that, you're going to see more restriction on the affected side. Mine's my left. What's that feel like to you?
Oh,
It's
bunching up there. It's
on the
painful.
inside, yeah, so we have to do that first. He's going across the body and he's feeling it on the inside, so you know the bicep tendon is trouble, probably anterior delt and probably pec. So I'm going to start with that. Could I borrow that tool? All right, I'll show you guys a lot of different ways to work this. I'll show you the non-scraping version because some of us just don't want to scrape it, and that's fine. It's less greasy not to. So you can pin and stretch this way with the palm. That's a little sticky, huh? I like to do it this way, and my hand is low, and I'm sinking in, grabbing that spot. When you're using the form, it's a two-phase process. The first is sinking and grabbing. It's like locating the problem, and the second one is putting a stretch or a movement on it. If you try and sink and move at the same time, you're missing a third or a half of what you're doing because you're not well located before you do the work. So I can feel the restriction there, and that's what I'm gonna work through. So there's this version where you can pin and stretch it, and you can also do some joint mobilization where I'm pushing on the lateral aspect of the glenohumeral joint so I can get glide into the joint. Feel that in comparison, that's a little different. It's more joint and less stretch. And there I can feel that superior aspect is really stiff right there. So that's the area I'm going to work the most. Always starting with the worst and then moving on from there. So of course we know this anterior capsule is bad because his cross body reach, he couldn't even try it because it was too hung up here. So there's that way of working on it. And then the bicep version. So without giving them the feeling of falling, you can push their hips in and their shoulder out. What you really want is for their arm to be free, for the shoulder extension to be easy. There's unobstructed. So you're going to feel for the bicep tendon. This is one of the few thumb moves I do, but it's really hard to get a forearm on this accurately. So I feel his bicep tendon here. Yeah. I think it's going to be more effective to scrape it, but I want to show this technique anyway. I like scraping for tendinous stuff, as I was saying before, because it's a lot more blood flow, so the recovery is a lot more permanent and progressive. So right here, I'm just grabbing it and then stretching. So I'm pushing down into shoulder extension this way, gently. You can see I'm controlling it by my leg. If I didn't have my leg here, he'd have this feeling of instability, because if the nervous system lets go, you know you're going to make more progress. If the nervous system is on edge, they're always going to fight you through the whole thing. So you want this to be as easy and efficient as possible. Here's one way about it. So it's partly traction and partly extension for the shoulder. So I'm getting some gain, but it's still a little catchy. I prefer to do it this way, so I'll put a little bit of a challenge on it and work through here. His subclavius is not bad, that's not the issue, but I feel it in the chest right there. So I've got that, and I can go through the pec, and I really feel this restriction through there. And by really feel, I'm talking about texture. This is like a bumpy dirt road right there, so no offense. So there's that, and I don't want to do too much of that until I release more of the insertion points here. Once I get this aspect going, that medial side will be much easier. Mainly, I want to get his bicep tendon open down through this direction. So you can see I'm putting a very gentle stretch, not as far as when I did the pin and stretch, down through the bicep this way. You okay? Are you pain-free in that path, or is it nervy shooting?
It's good. It's all right.
All right.
Just bumpy as hell.
Yeah. Right. So there's that, and then I'm not going to do all of it, but let's see if we've got enough to show you the next part. So try reaching across this way. How's that? Is that easier?
It's easier, but do you know where it moved to?
All right, cool, because that's what I want to show next.
Okay.
So bring that hand down. So we just had to get him enough movement in the anterior capsule so we could move on to the next spot. So ultimately, this is one of the top two, I would say, in terms of the most frequency you're going to need for treatments, because this common path between the supraspinatus mostly, because 70% of rotator cuff tears are the supraspinatus. So you definitely want to address that. You know, the supraspinatus is attaching to that top third of the scap, and then the infraspinatus is the bottom 2/3. So, but they commonly cross insertion tendons. So you're going to go along that tendinous path this way. So you can feel right in there. Whoa, that's the one.
Yeah.
Let's see if we can bring you up and over. So my favorite way to approach this is from the flip side. I can scrape this way. So 45-degree angle. So in general, I'm always using the least amount of force necessary to get the most amount of movement. So, so that he's gaining my trust and he's letting go and relaxing. And then I have way faster progress. Otherwise, I'm working against him. So, and then of course, I'm feeling for the texture and the change. I can already feel it letting go. And then I just work my way back to that scapular rim right there. And then that supraspinatus lets go. You can go to the lower portion for the infraspinatus, ooh, right there. And then that tendon. That's it, right through there. So I didn't spend much time on the pretest because he was snagged in the front, but see if you notice, just give that a break. And usually when I get the baseline, I'll put traction on the arm and then I'll bring it back and then I can get a clean baseline. Let's see what the across the body reach is. It's improved. It's not great, he needs more work. So we know we're on the right path, it's just more of the same. And then hitting more of the origin points. So you can have him on his side with the arm kind of half wrapped under the table, and then you can get much more of the scapular edge, and that will come across a lot better. When I'm touching him, I'm just barely feeling for what's going on, and I feel this is a muscle energy technique. So what I'm feeling for is what direction her hips want to go. So I'm feeling just super gentle. I'm going this way, and I'm going this way. And when I go this way, it feels really easy. When I go that way, it feels heavy. So what it feels like is she's going this way. So this hip flexor is short, which is why that foot is going back, and this one's turning forward. So she's twisted this way. But I'm not going to stop at that as a convincing argument. I want to see so many different ways of testing the same thing to see it, just in case I'm wrong. So do a full forward bend and then hang out there for a second. Tell us if you're in pain when you're down there. So are you hurting? Can you handle staying there for a
I can
minute?
stay, yeah. It's definitely a stretch though, I'm always
Oh, where do you feel?
behind.
Oh, just hamstrings. Okay. If this irritated your back, then we should back
Where
out of it.
I just for a split second, I felt it right here, but
Okay.
then it disappeared.
On the right side. So the hips are, come up all the way again, and let's even your feet out now. So slide this one. Oh, that's funny. Just a little further forward.
Oh,
That's,
really?
that's good.
Okay.
There you go. And then I'm looking at the carpet here. So do a full forward bend again, and let your arms hang. Okay, so does anybody see any ridging here?
Yeah.
What do you see? The left rib cage, which is weird. I'd expect the opposite. Maybe we've worked some spots, and this left hip is a little bit higher. Way to mix it up. And the right is a little bit lower. So slowly come up all the way. So we'll just factor that in. Whenever you see that, the rib cage higher, that's usually left rotated. So we don't know how that factors in yet. There's a lot of
Keep it exciting.
Yeah, that's right. It's keeping it interesting. So we see some evidence of the right lower being a problem because that right hip is clearly behind the left hip and she's pulling back this direction. We also see a torque into the left rib cage because the left rib cage is coming back when she does a forward bend. So now have a seat right on the edge here. So you guys are probably familiar with this. This is the Thomas test. And we want you on the very, very edge. And the reason is we don't want any barrier for your legs. We want them to hang with no resistance. So Hug your left knee in towards your chest. So there you go. And then just kick back, fall back, and then let that right leg hang. So there are two things I look at. One is how much extension does she have? And then the other is where's her knee going? There's just very slight external rotation, but it's really not bad there. So the other thing is, do you feel any kind of pinching when I push in here?
I do feel it in the hip in the front.
Okay.
A little bit. It's not
You shouldn't have that, right? Ideally.
Right, you shouldn't have that. That's a sign of the tendon being thick or the psoas being too tough, too dense
I
there.
feel it more.
Okay, so I'm pushing her more towards the midline. She's definitely restricted. What a trip. I expected the right would be the big problem. We're finding evidence that the left could be more of a problem. Let's switch legs. This side is higher up. You see there's a tiny little bit of a gap. Do you feel that?
Yeah,
And then-
and that is tight.
Do you feel the restriction in that hip flexor? Is there a pinch? No pinch. So which side would you start on if you were treating her? The left side. Yep, me too. Okay. Okay, we're going to start this way. So her right foot's going to be as far forward as she can tolerate, and left leg back, because we know that left hip flexor is pretty stiff, especially on the medial aspect. Did you guys notice that as I drifted in towards the medial aspect, it pinched more. So we're going to start with the worst of it. So this is not easy. I mean, there's ways to work on the psoas that are a lot easier than this. Pop up just a little bit that way. Stretching the psoas is the most effective, and you can also, I'm going to show you a palpation method, but the things I'm concerned about here is her left knee having an issue. So any pain in the knee?
The stretch is more at the hip.
Oh, good. Oh, that's the best sign. So she's in pretty good shape. I always ask where the stretch is felt. She knew the question to begin with, but if she's feeling it around her knee joint, then I want to tweak things around. Either hop that foot up or move this in a little bit and try and move the angle around so the more superior the better. In other words, if she feels it on the patellar rim, you're going to mess up her knee. But if she feels it up by her hip, you're going to free up her hip flexor and psoas. So that's the goal. And since she's feeling that already, we're going to work with it this way. So this is the first part. I'm getting rec fem and I'm getting the quads to let go, and then I can get the psoas moving. And you notice I'm constantly moving, and I'm kind of toying with the end range. You're never going to sit on the end range of any stretch because that is terrible for the joints. And then the other thing is you want to bounce, well, not bounce, you want to glide in and out of that burn, because the burn is ischemia, and as long as there's no fresh blood and oxygen in the muscle, it's not going to give way. The nervous system is going to be on guard. So the muscle gets more elastic when it's got fresh blood, so you're always moving in and out of it. Never stack. So here's the biggie. It really helps to have a strap, and then I'm going to put that around my hand and then cradle her foot. And then put my knee up, keep my spine totally straight, and this is the movement is like this. It's not a straight up movement, because that'll go right into her back.
Yeah.
It's tractioning out. It's like her knee goes away from her belly button, her belly button moves away from her knee. And that way you're tractioning the front of the hip joint. You're not digging into the joint itself, you're pulling the tissues open on the anterior medial part of the joint, because we know that that's where she's most sensitive. Okay, just let this go. Relax. And then the other element is I'm exploring internal and external rotation. When I internally rotate here, that feels pretty sticky to me. So I'm going to go at that angle. Where's that at, Jenna?
Up in the hip groin.
Good. So I'm trying to kind of edge in so I'm not too into my wrist joint. And then it's already starting to move here pretty well. Are you okay in that?
I'm good. Yeah, that's
in
fine.
the low back and all that?
Yeah.
Occasionally, you see how she's laying flat. Some people will prop themselves up, and when they do so, they feel it in their back. It's better that they're flat, and they might, like Scott said, they might have to contract in order to stabilize so it's not in their lower back. So as I'm repping it out, it feels like it's letting go pretty well. Okay. Let's see where we're at. So we've already made a good amount of gain there with her motion. That's all I would do for round one, and then come up to standing and, okay, good.
Oh, Lisa.
Turn over on your back. even though we found your left was tighter than your right, I'd make sure we go straight to your right side because that's your age-old pattern.
Uh-huh.
So I'm going to work you right this way. So, okay, so with what you were saying, my favorite way to go about that, because it's really the crossing point, you know, the attachment is the lesser trochanter of the femur. It feels like it's a groin muscle. So I can feel it right here, and the way I confirm that is lift your knee up towards my hand. There, you feel that tighten? Yeah, that's how you'll know you're. It's not purely the belly of the muscle, it's more the crossing point as it goes across the hip towards the insertion. So that's another way to do it. And holding a broad base of pressure, of course I'd rather use a tool here, but for brevity I'll show you guys this way. So just let that leg go heavy. You know how when we were doing the subscap, that's such a sensitive spot that I was trying to get the nervous system to let go by rotating? You can also feel what's sticking it with rotation and flexion. So flexion and extension right there is a little tough. And I'm working it this way. This is it. It's just a good amount. You realize how much time I'm spending on it because you want to desensitize that nerve. And pressure over time desensitizes. So then it's already let go quite a bit here. All right. Oh, let's test that motion here. So I'll come down here and
Yeah, I feel like right here on the left.
Yeah.
Stepped.
oh, okay. Yeah, we got to go through that whole pathway.
Okay.
So
you want me to
kick back all the
lie?
way. Let's see if we got. Let's see what these are like. So that one's pretty good. That's way down there. We only worked the psoas on that one, and then this one. Let's see if we make. Oh, we did make some.
Yeah,
gain
that's a
there.
lot. Still a little tight in there, but.
Yeah, I wonder if we got anything out of this. Yeah, there you go.
Mhm.
All straighten up. Feels like I'll drop this one though, so we get the same test. It's a little softer. Is there still a pinch there?
Yeah.
And then the other thing that I always like to couple this with, there's a couple different approaches to the glutes. And one of them, which is one of my favorites, is have you, since that left side is irritated, let's have you go this way and then settle down. So it's not a pigeon pose in yoga because we don't want to put a lot of lever force on the knee. You're tucking your heel towards the leg you're standing on. And then leaning down as low as you comfortably can. So for some people this is it, for some people they can make it all the way down. And then I'll have them switch it around and see what the difference is on that side versus this side. For me, this side feels like nothing and I feel more on the left. And then it's about what aspect you feel the tension on. Often when it's a right-sided problem, I see that lower medial aspect tight on the left. So this is the angle that I'm going to go through here. And we know that it's inferior-medial, like right in there. That needs work. So,
Yeah, that's tight.
yeah, this is quite tight. So there's the two methods we were talking about all day. So there's the forearm method, and then there's the tool version. So you can go, I should be standing on the opposite side and pushing inward this way. So I'm going to go sacrum inward.
In toward the hip.
Right in towards the hip joint from the sacrum. So, which is an ideal angle for the piriformis. So if there's sciatic issues, there's a powerful way to go. If the person's not in a major flare, this would be really intense if they're flared up. If they're flared up, let's have you climb up onto the table and come down totally flat. So if they're flared up, I'd go this way. So slide that leg up, 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 up. Keep going, keep going, keep going, right there. A little softer right there. So, and I'd be on the opposite side. I'd start right on the sacrum, and right away I feel there's tension right there. This is worth working on. And then I'd be going through here. So there's that, and you can also, of course, work this way. And when there's sciatic problems, there's two main origins. Of course, there's the L5S1 origin, and then there's the piriformis origin. So the whole issue here is a unilateral derangement, a twist, and that's what we found to begin with. And why is that twist happening? The hip flexor would cause some twist, if they're uneven. We found they were uneven. Glute tension on one side more than the other, and a difference, like it was higher over here and lower over here, which is typical right-hander pattern.
Genetics.
Sometimes the hip joints themselves, if you look at the acetabulum and the articular surfaces, It's very rare that people are totally symmetrical. Remember, we were saying that earlier. Nobody's totally symmetrical. The hip joints aren't completely symmetrical. So that could be a lot of the origin. A leg length discrepancy, a sprained ankle, a previous knee surgery, all of those can cause the twist in the hips. Somebody who always sits down, crosses their right over their left, that can cause that twist. Any ideas on how you would undo that, other than the work here? I mean, what kind of recommendations as far as an exercise would you tell them to stabilize? One of my favorites would be, let's give you right here. Like if you're sitting and you put a ball between your knees, you just have to make the pressure on your hips totally even. Put a ball between your knees, make sure your feet are totally parallel and at the same level, and hold there. And that's going to stabilize your hip girdle at the same level, so you're no longer twisted. And do exercises where they're contracting, and that machine at the gym where it's an adductor exercise, that can really help, as long as you have to be hyper vigilant that you're not contracting one more than the other, because most people end up doing that. And then my favorite is the slide board. When you're on an unstable surface, your stabilizers and rotators really have to work hard. So the slide board, you're pushing all your weight on one leg and then the other, and your hip rotators end up balancing out over time. So all of those help.